Emergency room physicians face a diagnostic nightmare when someone arrives with suspected mushroom poisoning. The reality is that most doctors will see maybe one or two cases in their entire careers, if that. Mushroom poisoning is rare enough that it's not at the forefront of differential diagnosis, which means initial misdiagnosis is disturbingly common. When someone shows up with vomiting, diarrhea, and abdominal pain, the default assumption is viral gastroenteritis, bacterial food poisoning, or maybe appendicitis if the pain localizes. Unless the patient explicitly mentions eating wild mushrooms, physicians might not even consider toxic mushroom exposure. Even when patients do mention mushrooms, many doctors don't appreciate the urgency because the initial presentation looks so benign. The diagnostic challenges are substantial. Symptoms are completely nonspecific in the early hours. There's nothing about the vomiting or cramping that screams mushroom poisoning versus any other gastrointestinal illness. Patients themselves are often uncertain about what they ate. Maybe they had mushrooms at dinner, but they also had chicken and salad, so which caused the illness? Timing becomes absolutely critical for predicting toxin type. If symptoms begin within 1 to 2 hours of eating, you're likely dealing with muscarine or other rapid-onset toxins causing primarily GI symptoms. If onset is 6 to 24 hours later, you need to worry about amatoxins. This timeline can guide empirical treatment, but only if someone thinks to ask detailed questions about timing. Clinical decision support tools are desperately needed in emergency departments. We need standardized mushroom poisoning protocols that prompt physicians to consider this diagnosis, regional poison control center partnerships that provide immediate expert consultation, and clear criteria for when to involve nephrology and hepatology even before definitive diagnosis. The critical history questions make all the difference. Exactly when did you consume the mushrooms? Not earlier today, but specific times, eaten at 6 p.m. Symptoms began at 8 p.m. versus eaten at 6 p.m. Symptoms began at noon the next day tells you completely different things. Can you describe the mushrooms or provide photos? Did anyone else eat them, and are they symptomatic? Where were they found? Treatment algorithms must account for uncertainty. When species identification is unknown, you treat for worst-case scenario. That means aggressive supportive care, early toxicology consultation, serial monitoring of liver enzymes even if initial presentation seems mild, and low threshold for admission rather than discharge. Case studies reveal tragic patterns of delayed diagnosis. A patient presents with what looks like a stomach bug, gets sent home with anti-nausea medication and instructions to stay hydrated. 36 hours later, they return in liver failure. The early opportunity for intervention was missed because mushroom poisoning wasn't on the diagnostic radar. The knowledge gap extends beyond individual physicians to entire healthcare systems. Many hospitals lack relationships with mycologists who could identify specimens. Poison control centers field calls, but don't always have mushroom-specific expertise immediately available. Laboratory capabilities for detecting specific mushroom toxins are limited. Most hospitals can't run these assays. Regional variation in mushroom species means that emergency departments in areas with high foraging activity need specific training. A hospital in the Pacific Northwest, where death caps are increasingly common, should have different protocols than one in a region where those species don't grow. The fundamental problem is that rarity breeds unfamiliarity. When physicians see thousands of viral gastroenteritis cases and maybe one mushroom poisoning, pattern recognition favors the common diagnosis. Breaking this pattern requires systematic interventions, clinical alerts in electronic medical records prompting mushroom questions for GI complaints, mandatory poison control consultation for suspected cases, and overriding the cognitive bias that common things are common with the knowledge that rare but deadly things exist. When the diagnosis finally is made, aggressive treatment improves outcomes. But those critical early hours, when treatment is most effective, are often lost to misdiagnosis. People die not because medicine can't help them, but because the help comes too late.